In this lecture, I'm going to look at those design features of a dental implant which have a direct effect on osseointegration. So the aims of this presentation on the design features which affect osseointegration are to explain the design features of an implant that directly influence the establishment and maintenance of bone contact with a functioning implant. And at the end of the presentation, hopefully you'll be able to recognize the specific implant design features that influence this bone contact, understand the importance of implant design to treatment outcome, and ultimately implant survival. Now, again, let's refer to our 10 fundamental keystones of implantology. And for this, we're going to be looking specifically at the first one in the list, which is good primary fixation for integration. So if we want osseointegration to ultimately occur, then we need to have good primary fixation. And if we intend to do immediate loading, we need to have good primary fixation. And perhaps we should also consider here early intervention for prevention, in that if we end up with a failure or osteodisaffiliation, so we're talking about a failure to maintain bone contact, then we need to remove the implants fairly early on to preserve the bone. And of course we also need to look at placing enough implants to meet the occlusal demands. So if you're intending to do early loading of a full arch situation, you must make sure you place sufficient implants to meet the occlusal loads. So if I was to do an upper case of immediate loading, I would certainly be looking to place at least 6 or more implants, because I'm relying entirely on mechanical fixation or osteofixation for the early stages of the process. So let's have a look at design overview. Well, there's over 1,300 different implant systems on the market today to choose from, and there are varying shape, dimension, bulk and surface material, thread design, implant abutment connection, surface topography, surface chemistry, the wettability of the surface, and the way in which the surface has been modified. So you could do an entire MSc just based on implant design alone and the way in which it influences osseointegration. Today we're just going to be looking at a few of the features that you should be considering when it comes to achieving osseointegration. We will be going back to certain other features in more detail as we progress throughout the program. So, common implant design shapes, where they're often described as cylindrical or tapered. You can have a situation where you have a hybrid situation, which we'll look at, which is a mixture of a taper and a cylinder. There's a surface topography, that is how rough the surface is, its wettability, which is very important when it comes to attracting blood and clot formation. Some implants are coated with calcium phosphate or tricalcium phosphate or other products such as hydroxyapatite, and these surface changes are done in order to try and improve the speed of osseointegration, to develop a functioning contact or bone that is able to withstand function earlier as possible, so that we can deliver our patients a functioning restoration. So there are surface modifications. Some of these surface modifications have a good track record and are proven, such as roughening the surface, but then there are other surface modifications such as galvanization, and maybe the application of certain chemicals to the surface, which as yet are unproven and may either prove beneficial in the future or may prove to be disastrous, as has occurred quite often in the history of implant development. Now, when we look at an implant system, often dentists confuse an implant system with an implant. An implant is the part that goes into bone, it's the fixture, it's not a system. A system is everything that supports the implant, starting from the design of the implant, to the prosthetic protocols, to the instrumentation that's used to place the implant, to the way in which it's loaded. It covers a myriad of different things. An implant system is, as I said, very different to an implant, which is just a unit. And in fact, some implant systems incorporate several types of implant design. So it's not just the implant. So when we look at the implant design, well, it should incorporate evidence-based design features that have been proven to support the process of establishing osseointegration and also of maintaining it during function. So it's one thing to develop a osseointegration after you've placed an implant. It's an entirely different matter to try and maintain that osseointegration going forward, and we'll be looking at how osseointegration can be lost over time and how we term this progressive osseo-disaffiliation. So an implant system is not just restricted, as I say, to implant design, but also includes all the accompanying instrumentation and associated surgical protocols. It is possible to sometimes mix and match protocols from different systems, but this should only be done by experienced clinicians. It is very dangerous for inexperienced clinicians to start mixing and confusing different restorative protocols with different systems. This is a recipe for disaster. And remember, the protocols do vary from system to system, so if you're used to driving one type of car, don't expect the next car to behave in exactly the same way. So if you change implant systems, make sure to learn the relevant protocols, as you may experience higher failure rates if you don't, because every system has, if you like, its own learning curve. Now, throughout this course, we're going to be looking at implant design features such as platform switching, whether they're tapered, whether you have an internal hex connection, whether the abutment implant interface, which is the junction between your abutment and the implant, can form a biological seal, or if not, whether there is in fact a microgap present. And a microgap is a space between implant components which allows the passage of bacteria and contaminants from the oral cavity into the soft tissues and onto the bone crest, resulting in bone loss or a localized peri-implantitis or osteomyelitis, which causes a little bit of bone loss, and this is often seen around the necks or heads of implants. And so the microgap is a very important feature of implant design, which is related to the maintenance and health of a functioning implant. So platform switching, well, in the implant that we'll be using during your clinical training, we'll use an implant which is platform switched, and that means that the diameter of the abutment and the diameter of the implant are not matched. Now, in the past, this was always considered that the abutment diameter would be slightly narrower than the diameter of the implant. So the diameter of the implant is 5 millimeters, say. The diameter of your abutment should be about 4.5, so it's slightly narrower. And this is platform switching, and it's a means of limiting the amount of crestal bone loss by moving the position of the biological width. Now, all this will be discussed in far greater detail in coming lectures. For the moment, I think it's important to appreciate that platform switching in a mechanical term, which means that the abutment is either narrower or bigger in diameter than the implant. The two are not matching. In older systems, the two used to match, and there was a butt joint between the two. Now we have this step, and as I say, this step is to incorporate the biological width. Not all implants have platform switching, and you will have to decide when it comes to purchasing your own systems whether you feel platform switching is a feature which is desirable or not. Here we have two implants, and perhaps you'll identify that the implant on the left hand side of the screen has platform switching, whereas the implant on the right hand side of the screen, the abutment doesn't have platform switching, in that it is actually resting on top of the implant, and there's no gap between the two or spacing between the two to allow the formation of this biological width, which is important to the maintenance of your crestal bone. So the implant on the left hand side is platform switched. It has that difference in diameter with a space between the two, whereas the other on the left hand side, the abutment, although it's larger than the implant itself, it doesn't have that recess around the neck, which is important to allow for the formation of a horizontal biological width. There are means and methods for different systems to establish this, but as I say, the majority of them establish it by having an abutment which is slightly smaller than the diameter of the implant. Others try to establish it by having this circular recess between the abutment and the implant. Now, another important feature is the development of a seal to eliminate the effects of a microgap. As I previously explained, bacteria can leak from the mouth down the inside of the abutment to come out at bone level, and this will cause localized inflammation in the area, resulting in crestal bone loss. And normally this crestal bone loss is in the region of 2 to 3 millimeters of vertical bone loss, and this is because of the irritation caused by the bacteria. So platform switching tries to eliminate this together with the formation of a seal, so that the bacteria first of all can't get into the region, and secondly, if they do get into the region, their effects on the bone are minimized by the presence of this recess. So very important features to look for in any implant is whether it can form a microseal and whether it has platform switching. Also, the type of connection between the abutment and the implant is very important, because Later on in function, if the abutment becomes loose in any way, this will predispose the abutment connection to distortion and fracture, as well as maybe leading to fracture of the head of the implant itself. So the manner in which the abutment inserts into the implant is most important, and you want to have devices and mechanisms which limit the effect or possibility of abutment loosening. And as I say, this is very important when we come to look at the long-term stability of the restoration, in that if an implant abutment works loose, as I said, you're going to have the extra clinical time to put it right. You might have a damaged prosthesis which needs to be repaired, and more seriously, you could end up with a fracture, which means that the implant is completely unusable. Whilst the implant is loose, of course, we are getting inflammation of the soft tissues, and this will result in bone loss from around the neck of the implant, another undesirable side effect of having a loose abutment. Many implants now try to carry the threads completely up the length of the implant, and this is sometimes done by micro threading, or other systems can use full threads. Again, it's very much dependent on the design features of that implant. Obviously, the amount of thread or the depth of thread that one can have is very much determined on the type of implant abutment connection. So we can see here that the wall thickness in this area here is quite thin, and this is our abutment, and this is the depth of our thread here. So we can see here that there is a very small amount of metal, and this would be a weak area and a potential area for implant fracture. As we move down the implant, we can see that this distance starts to increase. This improves the strength of the head of our implant. So this area is very important in maintaining the integrity of the implant and avoiding fractures of the implant itself. Obviously, a fractured implant, although a rare event, is quite a serious event and is very difficult to manage. Now let's look at the implant itself. Now, there are cylindrical and tapered designs. The implant that we're going to use on the course is a tapered design, and we'll be going into more reasons why this is advantageous to a cylinder. Both implant designs will osseointegrate. You have individual clinicians who are very keen on cylinders, and that you have those that are very keen on tapers. Market research has shown that the tapered implants are much more outselling the cylindrical implants. So if we go on what our colleagues are purchasing, there does seem to be a favourite, and that is our tapered implant. So we want a high thread because that helps preserve crestal bone by transmitting occlusal forces to the bone in a manner which it likes. It avoids what we call shearing forces, and again we talk about these in more detail in implant design. Surface treatments, again, these are important in establishing and maintaining osseointegration, but surface blasting does have an effect on the properties of the implant, the mechanical properties of the implant, which we'll look at. Some form of self-expanding taper expands the bone on insertion, and we'll be looking at that. That means that the implant taper actually causes osseodensification as it's inserted into the bone. Self-drilling, again, if the implant is self-drilling and tapping, this means that the number of stages required to insert the implant are reduced. It also means that less bone is removed, and this improves primary fixation. And if you remember what we talked about in the beginning, we said that primary fixation was very important if you intended to do immediate loading, or for that matter in establishing osseointegration. So if you can limit the amount of drilling or the need for any bone tapping, then that will improve primary fixation. If your implant is tapered rather than cylindrical, tapered implants deliver higher primary fixation. And this is why most systems that do immediate implant placement have a tapered implant, as well as most systems that do immediate loading have a tapered implant, because you need to be able to develop quite easily high levels of primary fixation. And thread speed. Now this is the number of turns it takes, if you like, to insert your implant. Obviously you can turn an implant through 360 degrees whilst you're screwing it into the bone. Now each turn of the implant will advance it into the bone by a certain number of millimeters. Obviously we would like to have a situation where you turn the implant once and it possibly goes 2 or 3 millimeters into the bone for one complete turn. Now in order to be able to achieve this, the space between the threads, or the thread pitch, needs to be quite wide, say 10 millimeters, or I'm exaggerating now, more like 1 millimeter between the threads would advance. It means that if you turn the implant 360 degrees, then that implant will be inserted into the bone by 1 millimeter. Obviously if you had a distance between the threads of 0.5 of a millimeter, then one complete turn would advance the implant into the bone by half a millimeter. So this is what is meant by thread speed, the amount of time it takes to insert that implant. There's a trade-off. If we have fewer threads, we're possibly going to get less primary fixation, and threading the implant also increases implant surface area. So the more threads you have on the implant, the better the primary fixation. Also, the more threads you have on the implant, the greater the surface area is. So as we increase the insertion speed, we lose out perhaps on surface area and ability to form reliable primary fixation. So implants come in a range of lengths and diameters, and on this course the diameters which we're going to be using primarily are a narrow diameter, which is 3.25, a standard diameter, and most standard diameter implants now are 3.75, and then we move up to our large diameter implant, which is 4.5. Now in my hands, these diameters of implants appear to be the most applicable to a variety or range of different situations and bone widths. That's not to say there's not better sizes or better diameters. Again, this is a choice for the individual surgeon. It's often you don't find implants drop down below 3.25 because they become too weak and prone to fracture. As I say, the standard diameter for most implants is anywhere between 3.5 to 4 millimeters, and large diameter implants tend to start at 4.5 and can go up to as much as 6 millimeters. But finding the bone available to accommodate a 6 millimeter diameter implant is quite difficult. Most implants come color coded. This is to help identify the diameter easily during surgery. And then they come as in a range of lengths, and our lengths are Our working lengths, or most popular lengths, are 10, 12 and 15. And in the two larger sizes we do short diameter implants, short length implants at 7.5 millimeters. There are systems that go down as low as 6 millimeters, and we'll be looking at implant dimensions and their relevance to osseointegration in other lectures. Since the term osseointegration came into existence some 50 odd years ago, the use of osseointegrated implants and for implants in general have changed. The paradigms of how they're used has changed. In the original protocol, implants were really just for edentulous patients. The implants were placed into basal bone, very little alveolar bone. This then moved on to implants being used to replace individual teeth, and implants being placed into alveolar bone. In the early stages of this process of development, the implants were placed into healed sites, and it was called delayed implant placement. And as things moved on in the 90s, people started to wonder if we could place implants into fresh extraction sockets. At the time there was a lot of debate about whether the implants would survive or not. Subsequently, it was found that implants could be placed into extraction sockets. And then the idea came about, well, could we reduce the loading times? Because although the Brannemark protocol set loading times of between 4 months to 6 months for the establishment of osseointegration, clinicians began to wonder whether it was necessary to wait quite as long for this to establish before using the implants, or even in fact if we needed osseointegration in the first place, or whether we could rely on osseofixation to hold our implants. And then ultimately we've come to the situation of immediate substitution, which is a combination, if you like, of immediate implant placement into an extraction socket and the placement of a tooth on top, placed into immediate function. So the process of implantology has really moved on and advanced over this 50-year time frame, as you would expect in any medical science. But of course, as we've extended the frontiers of what we can do with implantology, we've also increased the complexity, and with increasing complexity comes the increasing probability of complications and implant failure. Now, if we're going to be considering any form of early loading, and that could be restorations not placed into function, well, we need to have good primary fixation or osseofixation, and as we've stated now many times, this is purely mechanical. It relies on the grip of the bone. There is no biological bond between the surface of the implant and the bone itself. And when we're doing early loading, what we're hoping will happen is that eventually we will develop secondary fixation or osseointegration, and we're hoping this will occur as rapidly as possible. So the second point relies on the health of the patient. It's a biological process. It relies on the biological quality of the bone. The first process, primary fixation, relies on the mechanical features or quality of the bone. So there's two types of bone quality: mechanical and biological, and depending on what we're trying to achieve, we're depending on one or the other. So for primary stability, what do we mean by primary stability? Can we put a number on primary stability? Well, it's been said that we need to be able to prevent micromotion of the implant within the bone. And what we want is we want to get less than 100 microns of movement of that implant. So we don't want any more than 100 microns of movement of the implant within the bone. And just to bring this into some sort of idea of how much we're talking about, well, if we look at the diameter of a human hair, it's 50 microns to 100 microns. So we're looking at movement which is in the range of the diameter of a human hair. So very little movement indeed. Now, in order to provide this resistance to movement, and if we do get movement of our implants beyond this 100 microns, then we will not get osseointegration, and most likely we're going to get fibrous union and we're going to lose our implant. So we must have a situation where the implant is really well mechanically supported in the bone and able to resist movement. Now for this it depends primarily on our bone quality, and I'm talking about mechanical quality. And you can imagine that if you're placing an implant into a delayed site, you're going to have more bone available to mechanically support that implant than if it's going into an extraction socket where you're relying on bone at the apex of the implant to support the implant. So again, now bone preparation protocol, surgical protocol is very important, in that we don't want to excessively prepare the bone or remove bone, because we need as much bone as possible to support our implant. Now this brings into view the surgeon's own technical expertise and skill. Obviously those novice surgeons are going to be more prone to over preparing and damaging the bone than those surgeons who have experience of placing implants of say 50 or more. So this is very much operator dependent, and there's a learning curve in bone preparation as well. Now if we look at the design of the implant, is important. Obviously we need to have threads on our implant, and tapered implants are said to deliver better primary fixation than cylindrical implants, and they also require oftentimes protocols which don't involve the removal of excessive amounts of bone. And then ultimately how the implant is inserted in the bone. Is it screwed into the bone or is it pushed into the bone? So obviously if you're in very soft bone and you try to overscrew the implant, the chances are you will reduce the amount of primary fixation, whereas if you push or tap the implant into the bone, you're going to increase the chances of delivering good primary fixation. Now, although we've been looking at primary fixation in terms of delivering osteofixation, primary fixation is also equally important in delivering osseointegration. As we've said before, if we can't stabilize the implant to prevent its movement by more than 100 microns, we are unlikely to achieve osseointegration, the bonding of the bone to the surface of our implant. So even if we're using a delayed protocol, we want to ensure that we have good primary fixation of the implant in the bone. So for example, if we were to take an implant and just drop it into a fresh extraction socket and leave it rattling around in there, then it's highly unlikely to osseointegrate. Now, of course, as with anything with implantology, patient selection and assessment is paramount. Whether we're trying to achieve osteofixation or osseointegration, the way in which we select our patients and the requirements for the difficult protocols are very much patient driven. So let's look at some of the points that you should be looking out for, and that's the components of your implant system must offer some form of biological seal. They must be high quality, they cannot be prone to loosening. You must get a firm connection between the implant and the component. If you get a component loosening or detachment at any point during your early loading process, you will affect the load. The implants will be subject to uneven loading or excessive loading, which will cause micromotion or movement within the implant interface, and that will ultimately result in fibrous encapsulation of your implant or fibrous union, and you won't go on to develop that secondary fixation, that all-important biological osseointegration. So the component and the system you're using, very important requirement if you're intending to do any kind of immediate loading. Again, the patient's oral health should be excellent. That means they should have a stable occlusion, no mobility of teeth, no periodontal disease, and it goes without saying oral hygiene should be excellent. There shouldn't be any habits, in particular bruxism, and if the patient has got any kind of heavy occlusion or occlusion problems, these need to be rectified before you introduce an implant to immediate loading. And even implants which are placed using a delayed protocol will suffer problems and loss of osseointegration if you do not sort out the occlusion. And then we want a stable occlusion. We don't want to have to extract teeth either side of the implant because they have a poor long-term prognosis after we've immediately loaded it. So implants that are immediately loaded are relying purely on mechanical fixation. There's no biological bond, and if anything happens to disrupt the occlusion and mean that those implants are loaded badly, you will get movement of the implant, and then you will get breakdown of the bone interface or osteodisaffiliation. The implant will fall out and you won't get osseointegration. So it's most important. Patient selection is far more important when we're looking at immediate loading even than when we're looking at delayed loading. So very imperative that you carefully check the patient's occlusion before you even start. Soft tissue management. Well, after we've placed our implant, it's important to place a cover screw. This stops ingress of tissue or perhaps bone growth onto or into the internal connections of the implant. Obviously we don't want to uncover our implant and find that the post hole for our abutment has been occluded by bone. Also, the inside of an implant, if you recall, is a dead space. So when you close over the top of the implant, you've got this dead space where a clot can form, and then obviously that dead space can allow the development and growth of bacterial colonies, which could cause an infection. And indeed, you find that if you forget to place a cover screw on an implant, although it won't automatically lead to implant loss, it will predispose to losing crestal bone, so that when you uncover the implant, you'll find that you've lost more crestal bone than you were expecting. Equally, it's also important to remember that if you're using a cover screw, that you screw it down fully onto the surface of the implant. If you don't screw it down fully and leave a gap between the two components, then again this will allow for the ingress of bacteria and the formation of infections. Oftentimes you might find a small fistula above or near an implant which is suppurating, And when you look more closely at this, you find that in fact the cover screw wasn't fully screwed down, such that there was a small micro gap between the two components, and this allowed for infection to form, and you'll see the sinus will be draining from this area. And this is best managed by removing the cover screw, washing it, cleaning it, maybe disinfecting it in Corsadil mouthwash for a few minutes, and then reinserting it. Obviously you'll also clean out the implant internals and maybe just flush the internals again very gently with some chlorhexidine mouthwash in order to ensure that any bacteria still residing in the crevices of the screw threads or the internal hex are washed out and destroyed. So remember also that the implant has to pass through different connective tissue and soft tissue components. These have different histology, different makeups, but our implant itself is still just titanium. It doesn't change as it moves through different tissues, unlike our tooth, which is made up of dentine and enamel, and as it moves through different tissues, different bone to gum tissue, the elements of the tooth change to reflect this. This is not the case with an implant, in that if we look at the tissue components we're starting with, from the cervically moving apically, we have gingival epithelium, we have below that connective tissue, and below that we have the cortical bone or the cortical plates of the jawbone, and then this is followed by our trabecular bone. And these tissues all have their own characteristics. Gingiva is keratinized, the connective tissue contains collagen fibers. We have cortical bone, which is very dense, and trabecular bone, which has a very open cancellous structure and is very vascular and full of cells. Cortical bone tends to be avascular and has very few osteocytes in it, as it is mature bone. But our implant, which passes through all these tissues, is just made of titanium, and there's a connection, and this is the implant abutment interface, this connection between this component here and our implants, and this is where we can get bacterial leakage resulting in bone loss. It's also obviously an area of weakness, and commonly fractures occur in this region because it being an area of weakness. Abutments can become loose, and that really predisposes the patient to a screw or abutment fracture. So a clinical point here is to make sure your patients know that as soon as an abutment feels loose, or they're partially aware of it, they shouldn't leave the situation. They must return immediately to yourselves to have the abutment tightened. Otherwise there will be a fatigue fracture and they'll lose the abutment, or fracture the abutment screw, or even worse, as I've said, fracture the implant. And at this time the patients often blame either the dentist or the quality of the implant, neither of which is at fault. It's the fact that the patient chose to walk around with a loose implant for nearly half a year or more. In these situations the patients quite rightly say, well, nobody ever told me I had to come back if the abutment was loose. So please make sure that you do inform the patients of their need to maintain the implant in order to maintain that functioning connection between their bone and the surface of the implant. Now, when an implant is exposed or put into function, or is placed into the oral environment, it's necessary to place an abutment, and these can be either a restorative abutment or they can be a healing abutment. Healing abutments are just used to let the soft tissues maturate, keratinize and mature. So healing abutments obviously have to be connected and held to the implants, and there's two ways in which this can occur. Healing abutments can be screw retained or they can be friction fit retained. Again, the choice is up to the individual clinicians, but with this design you can see there is no screw channel, so it is held on by a friction fit in this area. Other abutments would have a screw in order to hold them into place, or are screwed down onto the surface of the implant. Now remember, healing abutments, whether they be screw or screwless abutments, have the possibility of working loose, and you have to consider, if the patient has a loose abutment, what would you prefer in practice? Would you like the patient to be walking around with the loose abutment in their mouth with a large micro gap between the abutment and the implant, which would be causing crestal bone loss through irritation and infection? Or would you prefer the abutment just to drop out and the soft tissues to close up over the top of the implant? My preferred option is that should an abutment work loose or be loose, it should drop out as soon as possible, because every moment that abutment is moving, rattling around on top of the implant, that's a possible implant fracture, that's a possible screw fracture, that's a possible abutment fracture, that is definitely bone loss. All these things are really not what we want in implant dentistry. So far better to have a situation where the abutment just detaches itself and the soft tissues close over the top, because you're going to have minimal damage and minimal things to sort out. The worst you'll have to do is provide a replacement abutment. So again, it's a matter of risk assessment, risk analysis. What's going to be more detrimental in the long term to the patient? Well, having a loose abutment, or even worse, having a loose abutment supporting a functional restoration, is really a recipe for disaster. Now we can see the two types of healing abutment here. We have a screw retained one on the left hand side and a non-screw retained or friction fit abutment on the other side. So if we look at how this works, we can see that on this side we have our screw in this area here, and this is a hollow tube, if you like, which allows our bacteria down. They come in and they escape in this region here or around here and escape through here, and we can see that this already has initiated some bone loss, and the bone loss occurs in systems as soon as the abutments are connected, and that's why Albrechtsen, in his classification of criteria for implant success, started measuring the bone from when the implant abutment was connected, because it took into account this initial loss of bone. So in his definition, he would start measuring the bone loss from this point going forward, if you like. He'd start measuring that dimension with the start point here, because he would have allowed for a little bit of bone loss, which always occurs with these systems when you connect this type of abutment with a microgap. So now if we look at the situation on the right hand side, we can see that we have absolutely no connection between here and here. It's a friction fit, so there is no possible way that bacteria from the mouth can get out. Here they hit that wall, and that's as far as they go. They cannot go out. Now interestingly, look at the effect that that's had on the marginal bone. it's hardly moved, it hasn't recessed back. In fact, the bone has actually grown on top of the shoulder of the implant because there's no micro leakage occurring. And this abutment also is platform switched. You have that little gap. On the other side, there is absolutely no gap there. If we move this away, we can see that we have no difference in the size of the healing abutment and the implant diameter. There's not that little collar space around there, and again, this does not help move or manage the biological width. Now, a particular type of impression to implantology is called the transfer impression. Now, most dentists are familiar with a dental impression, which records the topography of the jaws, the gums, and perhaps prepared teeth, and records margins. And this is used to make a model for the fabrication of a crown or prosthesis. Pretty much the same thing for a transfer impression, except in this situation we're not concerned about recording a preparation. We are really about transferring the spatial position and relationship of the implant in the mouth to the laboratory so that they can produce a model with the implant in that model in the same position as it would be occupying in the mouth. Now, again, we'll be looking at different types of transfer impressions as we go through the program. It's very important because if the transfer impression isn't accurate, we will not get a passive or accurate fit of our final prosthesis, and this will mean that the bone is put under excessive load because the occlusal forces will be not transferred to the underlying bone efficiently. Certain implants may end up being loaded more than other implants. Also, there's going to be a greater tendency for perhaps implant or component fracture if the fit isn't optimal. There are many reasons why a transfer impression will affect osseointegration. So transfer impressions are not just about taking an impression, they're also about ensuring the maintenance of osseointegration, as if your impression is poor, your restoration will not fit correctly. And implants are not like teeth, they have no adaptive capacity, they are very unforgiving. If a bridge doesn't fit 100% on a tooth, well, most likely that bridge will still have a relatively good functioning lifetime. Whereas with a dental implant, if you have 5 implants and the bridge does not fit 100% on all 5 implants, then the load will only be taken by those implants where the fit is good. So 5 implants, if 2 of them don't fit the restoration correctly, then it means 3 implants are taking the load. You cannot fill the gap with cement. You must have a metal to metal contact, and it must be fitting within about say 2 to 3 microns, unlike tooth restorations, which are acceptable at 25 to 30 microns gap. So there's quite a significant difference between the accuracy that's required from a dental impression and that of a transfer impression. And as I say, if the transfer impression isn't accurate, it will have a detrimental effect on the bone, because the implants will not all be functioning equally, or perhaps the implants will be loaded in an unequal fashion, in that the implants on one side of the jaw are taking all the load and the implants on the other side of the jaw are taking virtually none of the load. And then you'll start to see bone loss and implant plus component fracture. So the system of transfer we're going to be used is called a quick transfer. There are many different kinds of transfer systems which involve things snapping together, unsnapping. There's window tray techniques, closed, open techniques. These will all be discussed later on in the program, but we're looking in particular here at the effect of the transfer system to the maintenance of the integrity of your osseointegration. So the transfer base system that we're using relies on a base component and also the top part, which is a transfer. So if we look at this, we have our base component here, which is our healing abutment, and then on top of that we have our transfer, which is locked in the actual impression material, and this is for a closed tray technique. Now when we place an implant immediately, we may wish to take a impression in order to have the laboratory fabricate a crown and restoration. So in this slide we can see that the implant is inserted and there's a healing collar has been pushed, or a healing abutment has been placed on top of the implant. And this can be the situation with many different types of system. So here the implant, as I say, has been inserted immediately upon extraction, and we're intending to take an impression now to make our restoration. This radiograph shows the implant in the patient's jaw. It's been placed immediately in the mandibular following extraction of an incisor, and the healing abutment, or transfer base if you like, has been placed on top of the implant. This shows the situation a week following the removal of the tooth, and you can see how the soft tissues now have settled down. This is partly due to the fact that they were minimally disturbed during the extraction process. Obviously, if the extraction had been very traumatic, resulting in the loss of labial bone and damage the soft tissues, we would have expected to see a lot more recession. The quick transfer is pushed into the top of the healing abutment, and in this situation it's just pushed together. Other systems may rely on it being screwed. Now the advantage of this approach is that we do remove the need to actually take off the healing abutment in order to take the impression. And it's been suggested that the fewer the times that you actually have to take the abutment on and off the implant, the better it is, because every time you remove an abutment you cause a certain amount of damage to the soft tissues, you cause a little bit of tearing, the hemidesmosomal attachments get broken, and this causes a slight bit of inflammation, which can affect the level of your crestal bone. Next, the impression material is injected around the transfer, and this can either be through the transfer or just around the transfer. And as I've said, many transfers exist. Some of them are screw retained, some of them are square. There's all sorts of varieties that you'll come across. When we remove the transfer impression from the mouth, it's important to check that the transfer component is securely retained within the impression, and depending on the protocol being used, sometimes it's permissible to reinsert the component and sometimes it isn't. So be sure that whichever protocol you're using, that at the end of the day the transfer component accurately locates within the impression or is accurately held and firmly gripped within the impression. If there's any movement of the transfer device or coping in the impression, then it cannot be used. This will not be accurate enough for your technician or laboratory to construct an accurately fitting restoration. And as I've said previously, if you're either doing a delayed loading or immediate loading, the passive fit of the eventual restoration is essential. if you don't have a good accurate fit, then the loads will not be distributed evenly to the implants. Some implants will end up taking the brunt of the load. It will be traumatic loading. You will get motion or movement of that implant, and you will get osteodisaffiliation. So our impression technique, especially if we're going to be doing any form of immediate loading, is absolutely paramount. It's important at this point to be able to differentiate between a single stage protocol and immediate functional loading. In this situation, the implant has not been buried under the gum. It's a fixture that has been placed, or a fixture that's been placed level with the bone, and then you've placed a healing abutment of some description on top of the implant, and then close the tissues around that healing abutment. The advantages of this technique are providing the patient has a healthy occlusion and dentition. The advantages of this are that you don't have a second stage to actually uncover the implant, and when the patient comes back for review some 3 to 4 months later, you can then go on and take impressions, and you don't have to go through a second stage. So this is called a single stage protocol, and it's very useful in selected cases. And during the program, some of you will be using a single stage protocol on carefully selected cases. Now, the main thing about the single stage protocol is that the implant is not placed into load. This is not the same as immediate loading. There's no crown on top, and the implant is well out of the occlusion. So it's called a single stage protocol or single stage placement, because we don't intend to go back and do a second stage to uncover it. So it's pretty well a normal protocol with a slight modification. Now, if we look at this radiographically after healing, we can see quite nicely that the bone has actually grown over the top of the implant. We can see the bone is developed here and is growing on the ledge because this implant was placed slightly subcrestally. Now again, depending on the design of your implant, will make a point on how you are able to position the implant. So some implants you place such that the restorative platform must be level with the crest of the bone. Other implant systems, you have to have the restorative platform slightly above the bone or even at tissue level, and this is called a tissue level implant. This is a bone level implant, and other implants do permit you, as does this one, to even place the implant slightly below the bone crest, as it allows for bone to grow over the top. But this type of implant design relies upon obviously platform switching, and also it relies upon no bacterial leakage. As we can see here, there is no connection, no screw, no way that bacteria can actually get out into that area, that crestal area, because if bacteria were to arrive here, then we would lose that bone and our implant level would end up around about here or possibly lower, because of the inflammation caused by that bacterial leakage through the microgap. As this system has no microgap, this can't occur. So it's not possible with all systems or applicable to all systems, but with this system you can do it. And this goes back to what I said earlier about system design. Now we're going to look at the implant geometry, and we're going to look at tapered implant geometry in particular. So if we prepare an osteotomy site for a cylindrical implant and we place that implant within the bone, and we screw that implant into the bone like so, you can see that this piece of bone here, or this area of bone here, has had 1, 2, 3, 4, 5, 6, possibly 7 threads passing through it. This piece of bone down here will have only had 1 thread. So you can see that what we're getting here is the bone is going to be progressively, if you like, compressed and mashed and traumatized by the threads, and this is going to perhaps weaken the mechanical properties of the bone in that area and reduce our level of primary fixation. And of course, when we load implants, especially if we're going to be immediately loading implants, the majority, in fact, of the load is going to be taken over the first coronal third, 1/3 of our implant. The coronal 1/3 is going to take the majority of the loading. So we really want that bone to be as tough and as strong as possible. As you go further down the implant, the load dissipates pretty quickly and it's negligible. Probably the load being taken in this area is 0. So we really need to have good dense bone, good mechanical firm fixation in the coronal area of the implant, at the neck of the implant. And this is why with implants that are designed for immediate loading, the threads are taken up quite high on the implant and you don't have much of a polished shoulder in this area. As much as possible you want threads to engage the cortical bone, because the cortical bone has the best mechanical properties. It's denser and able to withstand loading in this region. Now if we look at a tapered geometry and we place our implants into a tapered osteotomy like so, what happens is that this area has a different thread diameter going through it. Originally it would have been that, and as you can see the threads drop down, and each time the threads drop down you're cutting into a fresh piece of bone. So originally you were using this, and then eventually you're using this area. And also the actual core diameter here is tapered. Now this taper causes a certain amount of osteocompression, and this is what we need in order to produce this phenomenon of osseodensification, as it's been termed, where you actually mechanically make the bone denser by compression. So this is why we use, as we're going to see, instruments like site formers, because they compress the bone and improve its mechanical quality for immediate loading protocols. Also, you'll notice in this design, as I said earlier, we have threads. Now these threads are actually engaging cortical bone, helping to dissipate the load better in this area, because again, as I said, the majority of the load is going to be taken by the first third or so of the coronal section of your implant. So you really need as much threads in this area to transmit the load. You will note that on smaller diameter implants such as 3.3 or 3.2 diameter implants, there's no threads and there's a smooth neck, and that's because of the mechanical features of the implant. It's just not possible to add threads in that section and retain the strength of the implant. If you did thread in that section a narrow diameter implant, it would be very prone to fracture in load, and as I said, the majority of the load is taken at the neck of the implant, so you really don't want to have an implant with a very weak neck taking all the load. So this is why narrow diameter implants do not have threads, and it's also why you shouldn't really be considering doing immediate loading on narrow diameter implants. If you can't be placing 3.5 and above, then you should not be doing immediate loading. You should be considering delayed loading. So here we have two types of implant. One on the left hand side is a cylindrical design. The one on the right hand side is a tapered design. Now there's also a situation called bicortical fixation or cortical fixation. And what this relies upon is that you actually engage the implant at both cortical plates. So we have threads here engaging our cortical bone, and we have threads here engaging our cortical bone. And this increases the mechanical stability of the implant. And again, if you're considering doing any kind of immediate loading, then you really need to have bicortical fixation. And you will not be able to get bicortical fixation obviously with short implants. So 10mm implants are really not appropriate for early loading. You should be looking at being able to place at least 15mm long implants, and they should engage both cortical plates, be that the floor of the nose or the sinuses. Obviously in the mandible it's a difficult situation, but the bone, fortunately for us in the mandible, tends to be D1 or D2, which is denser and better able to withstand occlusal forces and deliver good primary fixation. If we look at the design of the cylindrical implant on the left hand side, apart from the fact that each one of these threads would have cut through that cortical bone, mashing it up a bit, you can see there's no threads in this area, which reduces the amount of primary fixation, and also there's no threads at the tip of the implant, again reducing the amount of primary fixation and engagement. So the design of the implant that you're using, if you're intending to do any kind of immediate loading, is very important to the success of the implant. So let's look at varying tapers. We have here a 4mm diameter implant by 10mm long taper, and implant increases in length to say 17mm. If the taper continues unchanged, the diameter must increase in proportion. So if we start with our 10mm implant by 4mm diameter and we increase its length to say 17, so we add another 7mm, but if we maintain the same angle of taper over that 17mm, well, we're going to increase the diameter. So if we look at this diagrammatically, we have an implant with a taper at a certain angle of say like 20 degrees, and that gives a diameter at 10mm of, let's say, 4mm. Now if we were to make that implant longer to 17 and we didn't change the angle of taper, well, this is a situation. Obviously the diameter at the top would continue to increase with the taper, and we might end up with a diameter of 5.5 from 4mm if we continued with the angled taper. That would make the implant very difficult to use in practice, as there wouldn't be enough bone to cover it. Now, one way of overcoming this problem of a continuing taper is to consider a hybrid taper, and this solves the issue by combining the features of a taper with those of a cylinder. So basically we produce a taper till the required diameter is reached, say 4mm in the neck region. So at this area here we deliver our 4mm, and then from 4mm on we continue going in a cylindrical fashion. So this is a hybrid taper, and you will find that some implant systems produce this kind of implant, and it's okay, but of course when you start to get towards the coronal sections, you're back into the same problem of a cylindrical implant eating away all that coronal bone that you need for good primary stability. And although you might get good stability down here, this isn't where you need it. You need the primary stability in the first third or so of the implant if you're going to be doing immediate loading. If you're going to be doing delayed, then this kind of design isn't really a problem and quite suitable. Now, one way around this problem is to use varying tapers. So what we have here is, say, a 10mm long implant with a given taper, giving us a diameter of 4mm. Now, as I've said, if we increase the length of that and we keep the taper the same, then we're going to end up with a very large diameter at the end of the day. So the way around this is that we actually vary the taper. So you will find that the taper for a 10mm implant will be slightly different to that of a 12 and slightly different again to that of a 15. So the taper on the implant changes. Now, this does present problems when it comes to cutting an osteotomy site, in that you would need to have different finishing shape drills for the different tapers. So you would have to have 3 possible finishing tapers for 3 different types of taper. So this would be a very expensive system, very difficult to use and organize in practice. So again, the implant has to be designed so that it can be self-drilling and self-tapping, so that you don't need to have an unnecessarily large number of burrs. Okay, so just let's recap on the points covered so far with regards to establishing osteofixation. Well, as I've said, it requires a good bone quality, and this is its mechanical quality, its ability to stabilize an implant and resist micro motion. It also needs good biological qualities, in that it has to have a good reparative ability, so that if the bone does get damaged, it repairs itself quickly, and also that it can go on to produce osseointegration, which is what we rely upon long term for our successful anchored restorations. Now, looking at bone preparation, we need a protocol that does not result in excessive amounts of bone removal, and to a certain extent this is governed by our implant design. If our implant is such that it requires a lot of bone to be cut away, such as a cylindrical implant, or it requires the use of taps or countersinking, then all these activities remove the amount of bone, which will reduce the amount of primary fixation. That's not to mean that these are bad designs. It may well be that in a delayed type of protocol they work perfectly well, they deliver enough primary fixation for a delayed protocol, but these implant designs will not deliver sufficient primary fixation for early functional loading. And finally, the manner in which the implant is placed. As I said, is it going to be screwed in or is it going to be pushed in? If you overscrew the implant or turn it too much, you'll end up stripping the bone and you'll lose that all-important primary fixation. Now, let's have an overview at the mechanical integrity of our implants. And this was published in Biomed Research in 2015. And what we're doing now is we're looking beyond the initial placement of the implant to what happens when the implant is in long-term function. So we've actually achieved our osseointegration, and we want to avoid the loss of osseointegration or osseo-disaffiliation. So how do we avoid that, and what things will happen to affect the mechanical integrity of our dental implants? So over time, and when you place enough implants, you will encounter these problems. Implant fracture on the top left hand side, abutment screw fracture. This occurs when the patient has been using a loose implant for some time and has not returned to the surgery for the abutment to be screwed down, so the abutment screw has ended up taking all the load and it snaps. And this can be a very difficult problem to solve, especially if half of the abutment screw is jammed in the base of the implant. You have to try and remove the fractured section of abutment screw from the implant which can be very damaging indeed to the implant, and you'll end up losing the internal thread on the implant, which means you won't be able to place a new screw. Also, certain post screws are more prone to fracture than other types of post screw. This is an example of one such screw which is prone to fracture, and this is because you can see that the diameter of the screw behind the threaded section, that's the diameter in this section here, is actually narrower than the diameter of the threads, and that means that this part or this shaft of the screw is going to be more prone to fracture because it has less material in it. So these screws will always fracture in the thinnest part. We also get problems with abutment fracture, and often what happens is that the hex ends fracturing off of our abutment, and we're left with a situation where we have to remake the entire implant restoration and get a new abutment. And of course that's all well and good if the implant company is still in business, and if they are in business, do they still produce abutments for this model and make of implant? So these are all questions going on further into the maintenance of implants. And basically after about say 7 to 8 years, you can expect something like 50% of your implant restorations to return to you for maintenance. So it's very important that you make sure your patients understand they're committing to maintenance of the implants and that there will be need to carry out repairs. If we look at the severity of this situation, well, obviously the least severe one to manage is the abutment fracture. Then we have the post screw fracture, which again is more complex to manage but not insurmountable. But the worst kind of fracture is going to be our implant fracture, because that will ultimately mean either replacement or removal of the implant, or possibly both if that is possible. So a very complex problem to deal with is implant fracture. So the bite forces which have to be resisted. Well, the human dentition can exert large forces. Actual components range from 200 to 2,500 newtons, and lateral forces can go up to 30 newtons or higher. So what is the weight of a newton? Well, the weight of a newton is approximately the weight of one apple. So 1 newton means the weight of one apple, which is in the region of 0.2 of a pound. So we can see that if we are looking at something like a 2000 newton bite, then we're looking at something like over 400 pounds of compressive force on our implants, and all of this is being resisted by components which are less than 2 millimeters in diameter, such as the post screw or in fact the hex. So you can see it's not really that surprising that these things can fracture in function, and this is why we need to review implant patients at least once a year, not just to look at the health of the implant, but also to look at the occlusion and make sure that the occlusion hasn't changed. So do check the occlusion with a bit of articulating paper when these implants return to you for review. And vertical closing forces can reach between 42 to 400 newtons, and this is the speed at which the teeth clash together, because the above forces were just clenching forces, but also there's a dynamic component of when the teeth smash themselves together on a close. So there's an accelerative thing there as well. So these rather delicate implant components do take a lot of loading. I think you should just try to imagine a very delicate watch, and you place it inside somebody's mouth and you keep it there for a few years, and then you imagine what the watch looks like after those few years. So these bite forces need to be resisted. So more mechanical complications than biological ones. So we're going to find with implants going forward that we don't get so many biological problems, we get mechanical problems. So one of the things that I always say to people is we want retrievability for repairability. Retrievability for repairability, because we're going to get less biological problems and more mechanical problems going forward. A follow-up time of 29 years, more than half, that was 58% of the implants experienced at least one mechanical complication. So if you think the longer your implants are in service, the more mechanical complications they're going to have, just because implants are inorganic, as I've said before, they have no self-repairing ability whatsoever. So again, when it comes to selecting a system, it's most important that you know the system has been around for a while and is likely to be around for a while in future, because you're going to be called upon to perhaps carry out repairs on your implants. While a mean time of 5 years is reported for biological complications, it becomes 7.5 years for mechanical complications. So that's why I said at the beginning that after about 7 to 8 years, expect patients to have come back with mechanical complications. Biological complications are going to occur on the whole in the first 5 years, and then they don't normally crop up. It's your mechanical problems that take on more of a significance. So an important point to keep in mind is that mechanical complications occur significantly later and more frequently than biological complications, and yet their severity is much more pronounced because of the complexity of retreatment that is required. So if you have a biological issue, well, ultimately that will probably result in osteodisaffiliation and the loss of the implant, and then you can replace the implant and start again, or maybe need to graft the area. And although it's not a pleasant prospect to have to do this, it's not that difficult either compared to the mechanical complications where you've got broken components which may prevent you from actually placing a new restoration on top of the implant, and then you have a situation where you have a fully integrated implant which can't be restored. Mechanical complications. Well, the most common mechanical complications consist of the screw and abutment fracture. So the screw can fracture, or the post screw fractures in about 8 to 9 or possibly even as high as 10% of the time. Now, some screws, some post screw designs are going to be more prone to fracture than others, and we're going to be looking at that in a little bit more detail in some other lectures. And then we have abutment fractures, and again the design of the abutment is going to make it more prone or less prone to fracture than others, and again we'll be looking at this in more detail. But just to remember, the sort of top of the list of mechanical problems is a post screw fracture followed by an abutment fracture, and these are perhaps the least severe of the mechanical problems to deal with. Now, implant fracture has a 5-year complication rate of up to 4%, and this is a much more severe problem to deal with. Fortunately, it's also a rarer problem as well. The fracture mechanism is metal fatigue, which relates to the repetitive character of occlusal loads during mastication. Fatigue fractures start to form while the implant is functioning. So we've got continual cyclical loading of our implants in function, and this is providing the force to initiate our fractures. So if we look at scanning electron microscope pictures of a fractured implant, Now the yellow arrows are cracks in the surface of the implant, and the red arrow actually shows some blasting media that's been used to roughen the surface of the implant in place. So we've got these cracks appearing, and there's also, if you look carefully in this picture, in this area here, a very fine crack starting to develop. Now this is an implant that was in function and has fractured, and if we look at the magnification here, it's at 10 microns. So it's quite a high magnification here. This is a 10 micron scale. Remember, a hair is 100 microns and a red blood cell is 7 microns. So this is a sort of magnification we could see a red blood cell, and these are particles here of blasting media that have been used to create the rough surface. When it comes to implant fracture or implant component fracture, then a very important concept to understand from engineering is endurance limit. So what is the endurance limit? Well, it's the stress level below which a specimen can withstand cyclic stress indefinitely without exhibiting fatigue fracture. So what are we looking at? Well, the specimen is going to be our implant or our abutment or our post screw, and there's going to be a stress level at which those things are going to fracture, and that's called the endurance level or endurance limit. So stresses above that will result in fracture of the component or implant, and stresses below that level, that endurance level or limit, those will be withstood indefinitely and your components will not fracture. So this endurance limit is very important to the survival of our osseointegrated restoration. So remember that these implants are subjected to cyclic loading. The teeth come together 4,000 to 5,000 times a day, so that's a lot of cyclic loading, and we have to make sure that we don't exceed this endurance limit, because if we do, we'll end up with fractured components. So grit blasting is used primarily on our implants to produce a roughened surface. Now the roughened surface is very useful or very beneficial in the formation of early osseointegration, and it increases the surface area of our implants. But grit blasting comes at a cost. So it's been found that the grit blasting of titanium implants, be they either commercially pure or alloyed implants with aluminium in them, this grit blasting influences the fatigue endurance strength of our implants. So this is very important when it comes to looking at the sustainability of our implants in function. So grit blasting of titanium alloy implants reduces its endurance limit by 30 to 40%. So just by merely grit blasting the surface of an implant reduces this endurance limit, which is the stresses it can withstand before it fractures. So nearly a 40%, 50%. This is quite an effect. And remember, grit blasting also removes material from the implant, so it affects the implant diameter, and also a rough surfaced implant produces higher torques when it's inserted because it doesn't cut as efficiently. So although grit blasting has some biological advantages, it also has some mechanical and surgical protocol disadvantages associated with it. So what you gain with one hand, you lose with the other. And fatigue cracks are initiated at remaining ceramic particles or in the sharp grooves with large stress concentrations exist. So basically the particles are left behind from the grip plastering process. Small particles are left embedded in the surface of your implant. Now again, depending on the cleaning protocols, the size of the particle, the pressure used to produce the blasting, these all influence the effect they have on the endurance limit. So the red arrows are remains of blasting material associated with a crack. So here we can see in this area here there's a blasting material, most likely aluminium oxide, and here we can see cracks appearing and they're, if you like, associated with that that material that's been left behind, that blasting media that's been left behind, because these areas where they've produced an indentation act as points where stresses can concentrate and build up. So stresses will find a weakened area, they'll find a point and they'll focus in on that area, and this is where the cracks originate from, where the blasting media has been left behind. So apart from wanting to have a very clean surface for osseointegration, we also want to ensure we have a clean surface so that we reduce the probability of fatigue fractures later on. So again, if you're keen on buying cheap implants, then expect that their surfaces won't be as clean, that there will be a lot of surface contamination, and this will affect the long-term performance of the implant. Here we can see a fractured implant, and this one has fractured at the apex, and this is because this is where the load was being taken, and also it's because it's the thinnest part of the implant, so the thinnest part is going to be the weakest, and as I've said, where you've got a reduced diameter, that's where you're going to get your fracture. We can surmise the reason for the initial bone loss was the presence of plaque and calculus. So here in this area we can see that the implant hasn't been well maintained, or we can't even make out the metal. It's covered by plaque and calculus, and this has resulted in bone loss down the implant to this point here. So we've had bone loss in this area here, and in the apical area most likely the bone was still integrated to the surface of the implant, so the implant was being cyclically loaded in this area, and we end up with a fatigue fracture. So you can see how peri-implantitis will lead to bone loss. Bone loss will lead to increased loading on our implants. This load and stress exceeds the endurance limit of the implant material, and we end up with a stress fracture. Here again we have an example of a stress fracture through the vertical part of an implant, and this has most likely occurred during insertion. Now the implant has fractured down its length, it can't be used, it has to be removed. And when we remove such implants, we end up having to use a bone trephine, and this has removed bone. It's a complicated procedure, and it's going to mean that the subsequent replacement of the implant is that much more difficult. So we can see quite clearly our fracture running down through the entire length of the implant. This interesting article looked at 100 dental implants which were lost due to biological reasons and which were not fractured but still intact. Now the implants were subjected to scanning electron-microscopic examination, and this examination revealed that 60% had cracks and fully developed cracks. Also, that a high incidence of embedded particles were observed in close relationship with these cracks or defects. And here is a picture of one such specimen, and we can see here the actual embedded material, which is just in this area here, and we can also see the crack running through the metal structure down like this. So now this implant had never actually fractured, it was still intact, but you can see that the cracks were forming in this functioning implant, which failed due to biological reasons. So bearing in mind that these were functioning implants removed for biological reasons, not because they were fractured, it should be noted that because the vast majority of the cracks were associated with ceramic particles, this indicates that no new cracks were actually formed during function. This means that had any fracture occurred in the future, they would have developed from pre-existing cracks associated with the embedded media. So this is quite an interesting finding, in that it means that a lot of the implants that we're inserting into our patients have already got cracks and defects in them. So they're already prone to fracture. So it's even more important that we make sure that we don't inadvertently overload our implants. I'm just going to bring this lecture to an end now by briefly mentioning the effects of implant geometrical design. And it should be remembered that smaller diameter implants are associated with higher rates of metal fatigue fracture, and that they should really be avoided in areas of high occlusal load, and in particular the posterior regions of the mouth. And if they are used posteriorly, then they should be splinted together so that they can resist occlusal loading more favorably. To round up this lecture, you will recall that we've looked at how the design features of an implant can affect its ability to deliver a good primary fixation, how the insertion protocols can also affect the ability of the implant to be able to provide good primary fixation. We've looked or mentioned how primary fixation is important for osseofixation if we're intending to deliver any kind of immediate function, and long term how primary stability is important for the development of osseointegration. And going forward from that, in that after we've established our osseointegration, how the design features and the way in which the implant has been manufactured affect its durability in function. Obviously, osseointegration can deliver long-term restorations in excess of 30 years, but unfortunately our mechanics are not so reliable, and there will be component fracture due to metal fatigue and the cyclic nature of the loading that they're subjected to in the oral environment. So it's most important to have a thought of retrievability for repairability. Try not to make anything permanent in the mouth. Avoid permanent cements, because at some point you're going to have to get back to that implant to carry out a repair. And remember, our biological problems are going to perhaps occur in the first 4 to 5 years. Then going forwards from those, we're going to see an increase in mechanical problems.